Welcome to today's webinar. Our topic for today is 3 extrinsic factors of wound development, taking a deeper look. My name is Megan Klein, and I will facilitate our meeting. Please note, the information contained in this presentation is intended to provide general information, but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting qualified legal counsel. Today's webinar will be presented by Endsjo. Anna is an occupational therapist with a Master of Occupational Therapy degree from Nova Southeastern University and a Bachelor of Nutrition and Dietetics degree from the University of Delaware. Anna has worked as an occupational therapist since 2001 in a variety of treatment settings, including acute care, subacute care, outpatient, acute rehab, long-term care, and as a lymphedema certified therapist. She has worked mostly with the geriatric population, dedicated to the betterment of the treatment of the elderly in long-term care centers. Her focus has been on seating and positioning and contracture management of the nursing home resident. In January 2016, she started a new role with Comfort Company as the Clinical Education Manager for the Long-Term Care Division. In this role, she developed an education program for long-term care settings with the hope to guide other therapists, rehab directors, nurses, and administrators through educational guides, blogs, webinars, and live courses to understand the critical role proper wheelchair positioning plays in the prevention and treatment of serious health complications within the long-term care center. Anna joined the Permobil family in October 2017 and is excited to continue her efforts with the team as Clinical Marketing Manager of the Long-Term Care Division. And now, please welcome Endsjo.
And thank you to everyone who has taken time out of their very hectic, busy schedules with COVID to join us for today's webinar. So to jump right in, I'm going to go ahead and start with our objectives. And the first objective for today's course is that I would like for you to be able to, number one, name 2 pressure redistribution methods to protect, I'm so sorry I can't see my screen, to protect the client from peak pressures on bony prominences. Number 2, I would like for you to be able to name 2 ways that shear can occur while sitting in a wheelchair. And then the third objective for today is I would like for you to be able to name 2 properties to look for in a cushion cover to fight microclimate. So one of the things that we are going to be learning about today, obviously, are the 3 extrinsic factors of wound development, which are pressure, shear, and microclimate. But who do we deal with when it comes to long-term care? We deal with the geriatric population. And the geriatric population is even at higher risk for attack in a seated posture from those 3 extrinsic factors due to the natural progression of aging. So we're going to go over some of those natural age-related changes that really compromise the skin integrity that make our elderly client more susceptible. And this is really important because in 2019, in the fall, the NPIAP actually put out a list of risk factors of clientele that should be using specialized skin protection equipment in order to protect them from wounds. So now it's going to make more sense because one of those risk factors was age. So what I'm going to do through the next couple slides is I'm going to be comparing on the left-hand side of this kind of cutout of a skin cell, 3 healthy layers of the skin in a young individual compared to what happens when our individual is elderly or has multiple comorbidities in a disease process. So the first thing, actually I'm going to go back to the slide for a second. The first thing I want to talk about is just remember that there are 3 layers of the skin. We have the first outermost layer, which just put a sweater on, so I've got to pull it back. We have the first outermost layer, which is our epidermis. And this is what we can feel, what we can see. This is the very thin layer that really comes into contact with everything in our environment. So here it is. Then we have this middle layer, this pink layer, that houses most of our stuff, okay? Blood vessels, proteins, etc. And it makes up for the thickest part of our skin, which is about 90%. And then we have the third layer of our skin, which is our hypodermis, which is mostly made up of fat cells. And what that does is acts like a nice thick barrier so that it can withstand a lot of trauma and pressure coming from the outside environment. The other thing is that the fat layer, the fatty layer, really acts as insulation, much like the insulation in our walls, to help us control extreme temperatures dealing with microclimate. But as we age, one of the big things that happen, especially here on the epidermal layer, is that we lose our waterproof oily coating. So we're a little bit like a Labrador retriever, I guess, where we have this oily coating in our coat that really helps us to do two things. It lubricates the outside of our skin so we don't get cut and bruised and things very quickly. And it also allows us to maintain our moisture level. So it helps to keep excess moisture out so that we don't have maceration of the skin. And it also helps us to lock in much needed moisture to maintain a good level of hydration. But as we get older, we lose this oily coating. So our skin becomes more dry and brittle, easier to break open. And also, it's harder to maintain the correct level of hydration. So it's easy for excess moisture maybe coming in from incontinence or drainage to really soak in and macerate this top layer and actually just slough it off altogether. Another big change is that here in the epidermal layer, we also have cells called Langerhans cells. And I always joke because I say that I sound very educated when I say the word Langerhans. But we do have these Langerhans cells, and when we're young, they're very plentiful, as you can see on the left-hand side of the screen. And then as we get older, they diminish. And what do these cells do? They actually act as our initial warning sign. So they make the skin temperature very hot or warm to touch. They cause the reddening of our skin so that we know that something's attacking our skin and that we can then do something about it. So as they diminish when we get older, something can actually, pressure or shear forces can actually be taking effect, and it won't tell us as quickly, and we might see somebody break down a little faster because we've lost these Langerhans cells. Another thing that happens with age is that the layers of our skin just naturally thin. So here again, in a young, healthy individual, it's very thick. And as we age, with each decade of life, it decreases by 6.4% after the age of 30. So you can imagine why a young person won't have as much skin breakdown as someone who is in their 80s, because when they're 40, 50, 60, 70, and all the way up to 80, their skin has thinned by 6.4% each of those decades. So we just don't have the same barrier to withstand constant pressure or shear forces, and the skin is more likely to break open. All right, some more changes that definitely need to note that's happening to our geriatric population that makes them more susceptible is the fact that our epidermis, this outermost layer that I'm talking about, it has no vascularization whatsoever. There's no blood vessels. So that means it doesn't feed itself its own oxygen and its own nutrients. That actually comes from the deeper dermal layer. So there needs to be some kind of junction to feed from the dermis to the epidermis. And that comes through this white, wavy, finger-like projection, which is called our dermal epidermal junction, that really locks the two layers of skin together and allows oxygen and nutrients to be exchanged so that we can maintain the skin integrity and also to help heal a wound if one occurs. But as we age, it kind of flatlines. And we know the connotation of flatlining. Not good. It kills something off, right? So as our dermal epidermal junction flattens out, we don't have that same exchange of oxygen and nutrients. And when a wound does occur, it takes much longer to heal. And it also doesn't allow the skin to stay firm and resilient like it did when we were young. All right. Some other changes happen more in the dermal layer are the fact that in a young individual, our dermis has protein called collagen and elastin that really give us two things. It gives us our tensile strength and our flexibility, so our pliability. So tensile strength is actual how much pressure something can withstand before it breaks open. And then the flexibility is how far can it be, pushed beyond its limits before it will break open, okay? So the thing in young, healthy skin is that collagen and elastin are really interwoven very nicely, and they're very organized, and they kind of make what you can see a net, like these little waffle fries from Chick-fil-A that you can see. But as we get older, they kind of become disorganized. They're no longer interwoven. They become less in number. So our skin just can't take as much pressure, and it also loses flexibility. So when, constant trauma or pressure or shear is applied, it's easier to break open the skin, okay? The other thing is that when we get older, we really worry about our patients maintaining their hydration, making sure their kidneys are functioning, but not only, their organs, but also their largest organ, which is our skin. So we need hydration in our skin. And if you think about our patients that are trying to go through range of motion, let's say, right? And you're having a hard time getting them to full range. Well, go and do some pool therapy and get them in the water. And because you now have no resistance, you can actually take them through a full or larger range of motion, correct? Well, it's the same thing with our skin cells. When we have adequate hydration and we have good moisture content in our skin cells, when something is placed, a stress or strain is placed on the skin, those elastin fibers, like I said, will give and deform and then boom, bounce back into its natural shape. And when there's a good moisture content, it can actually go even further because there's no resistance, just like when we get in pool therapy, and you can go even further. So you can actually withstand more stress and strain when there's a good hydration level. And that's called our viscoelastic property of our skin. When we lose that hydration and things start to go away as we get older, it doesn't take as much to just boom, break it open, and that skin is going to now form a pressure injury. All right, some more skin changes to note is that here in the dermal layer as well, that's where we house our sweat glands. And this is important when it comes to microclimate, because as our temperature rises, or the temperature between the seat surface and our body rises, what happens is that a young, healthy individual will produce sweat here in the sweat glands. The sweat will then travel through these ducts and be excreted out to the epidermis that then will evaporate and cool the surface of our skin. But as we get older, the number of sweat glands is truly diminished, and we don't have that capacity. So we lose our ability to dissipate heat. So we actually need to start to look for products that can do it for us. As well, we have those sebaceous glands, and sebaceous glands are in charge of making that oil that I talked about, that make that oily coating that lubricate our epidermis layer. And so in a young, healthy adult, no big deal, we produce that oil. They're then excreted through these ducts and released into the epidermis. As we get older, again, they're diminished in number. So what happens is we lose that oily coating. The skin becomes more dry and brittle, and of course, excess water can enter into the skin. All right, and then the last layer of our skin is that fatty layer, that really kind of that barrier that acts like as a shock absorber and also helps us to regulate extreme temperatures. So that is also going to thin as we get older. So we are just not going to be able to withstand as much shock and trauma. And then what's below our skin? Muscle, blood vessels, bone. And so everything below the skin is more susceptible and is going to be damaged when that barrier is reduced. And again, we're not going to be able to dissipate heat and regulate our body temperature as well when that insulation is diminished. Okay, so the next slide I have for you is talking about common areas of skin breakdown. And this more is just as a reference slide. And I think we do a really great job in our nursing homes when we think about the bed surface, when someone's in supine, and we really know that the heels are at risk to break down, or maybe the sacrum is at really high risk. But we've got to then translate that into the seated posture and realize there's a lot of hot spots in the seated posture as well. And so this is just to kind of remind us that it's not just on the pelvis. We also have to think about what's going on along the trunk, the head if you're using a head support, definitely around the rib cage if you're using lateral supports, and of course on the leg rest, especially at the heels against the foot plates. And then there are both intrinsic and extrinsic factors that actually make us more susceptible to wound development. And again, the NPIAP made a very long list of risk factors that we should be aware of as healthcare providers. And if those risk factors are present, then we should be doing something and trying to give our patients equipment to be proactive and prevent a wound from happening versus reactive once the wound has already happened. And what I want you to do looking through this list is, geesh, this list, a lot of our geriatric population deals with these comorbidities and these issues. So our population is very, very high risk of breakdown from intrinsic factors. Now, with that being said, intrinsic factors are things that are happening from within our body. You and I as a therapist probably aren't going to be able to fix this issue. This is going to kind of lie on the heaviness is going to lie on the shoulders of the medical team, like the doctor and the dietitian and the nurse and the pharmacist, to really look at lifestyle changes, dietary changes, medical management, so that we can try to decrease the risk from some of these internal factors. The extrinsic factors, which is what this course is focusing on, are factors that stem from the environment outside of us. And these are things that you and I as therapists can directly address through our equipment choices. What can we do to fight pressure, shear, and microclimate? And so I'm going to start to go through these individually to really understand the mechanism of each. What is actually happening to that person in the seated posture from the wheelchair that is causing that injury due to pressure, due to shear, and due to microclimate? And I think pressure is the one that we understand the best because we feel it all the time. You're sitting here in my course and you're sitting here watching and you're feeling the pressure build up in your ITs. So what do? You shift over and rotate, and now I'm sitting in this position. Now I'm feeling pressure build up in my greater trochanter, so I'm going to sit up tall for a while. And we're constantly repositioning ourselves to alleviate pressure buildup, probably unconsciously because we feel that, all right? So this is something that people understand very well because we constantly feel it. And pressure, by definition, is just a continuous force on or against something that you make contact with. And what do we make contact with in the wheelchair? The back support, the seat cushion, the headrest, laterals, foot plates, anything that our body is touching, okay? And what happens a lot of times in our population is they get weak, they slide down, and then they sit right onto some bony prominences like the sacrum or the ischial tuberosities. They really dig then into the surface they're sitting on, and a peak pressure is developed. And right where all that pressure is going right under that IT, you're at risk for a wound. And when we look at the seated posture, we have to remember that pressure coming downward is coming from gravity that's pushing me into my chair. And then from the seat surface, you have a counter pressure coming up from the cushion. So everything between those two forces is being compressed. And that would include our skeleton, our skin, our soft tissue that is going to break down right under a bony prominence that's continuously being pushed and compressed. And when it comes to the back support, we push into our back support and then the back support pushes back. So again, there's this constant pressure compressing everything within our spine. Again, thinking back to that, hot spot area of common areas of breakdown. That's why it's not only on the pelvis in the seated posture. So when is pressure at its peak? There are certain situations that are going to make a patient more susceptible to breakdown. And again, we're dealing with the geriatric population. They're weaker. They're going to slide down in their chair. And as they slide down to the sacral sit, they're going to be sitting onto that bony prominence. But unlike you and I, who can reposition ourselves, when they slide down, they can't get themselves back up because they have weakness. So they sit in that posture for long periods of time, and the skin will break down. Pressure will be at its peak. The other thing is, a lot of times, and I know this very well as a rehab manager for many years, we have kind of budgets that we're supposed to be watching. And a lot of times that makes it very tempting to use both general use cushions, the sling back that comes on the chair, to use those K90 wheelchairs that really have that fixed 90-degree angle, because I can get one for, $150. But the truth of the matter is, think back to what I said about the MPIAP. They know that there are specific risk factors that are going to make a population more susceptible to skin breakdown. One of those risk factors for sure is age. And 2, multiple comorbidities, which many of our patients have. So we need to think, we need to be proactive and preventative. We're already dealing with a high-risk population. The NPIAP's guidelines say we should be giving them skin protection equipment, and so that's exactly what we should do. We've got to stay away from that tempting general use product that has a great price tag of maybe $50 for a cushion, but it doesn't have anything built in to help redistribute pressure, or it's not constructed in a way that's going to stabilize someone and take away pressure from a small vulnerable area and onto a greater surface area. And we also have to stop thinking that a cushion alone is going to do that. We know better. We're therapists. We know that I'm never going to truly be able to fix the trunk and the head without thinking of what the pelvis is doing, and we're not going to be able to fix the pelvis without really thinking about what's the trunk and the lower extremities doing as well. So they really shouldn't be thinking, oh, by just placing a cushion under someone, everything else is going to fix itself. And the other thing is, when we order wheelchairs, they come with just a vinyl backing or some type of flimsy support that has to be put on the wheelchair just to send it out the door. Because as a manufacturer, they can't not put something on the back or you fall right through. So they've got to put something. And I was asked a really great question one time. They say, well, why do they even bother to put that back on there if it's no good? And I've always made this analogy. And I've always said, you can go and buy you want to buy a pair of sneakers, and you can go to Shoe Barn and get a $50 pair of Saucony, or you can go to a running store and get a $180 pair of Saucony sneakers, right? And what's the difference between them? What kind of foam are they using? What's the kind of gel are they using? What does the toe box look like? What's the shape of the shoe? Is it going to help with someone who's a pronator? Does it have a high arch? Does it have a small arch? So there's certain things built into this $180 shoe that makes it better, that's going to help someone with certain issues. But what is not different between these two shoes is this thin, flimsy foam insert that they put inside. They can't sell this shoe without a foam insert. So they're not putting money into this. They put that in there, and they know that if you have something wrong with your foot, like a bunion or plantar fasciitis or Achilles tendon issues, you need to replace this with an orthotic or a specialized insert that actually can accommodate or correct the issue that you have. So that's the same thing with the back support. We have to stop using slingbacks, and when someone has a kyphotic spine, or they have a scoliosis, or they have a rotation, we need to take that slingback off and replace it with something that can accommodate and correct for the curvature that they present with, so that we don't have peak pressures and breakdown along the spine, okay? All right, so when we're understanding pressure, this picture right here, what I've done is I have somebody sitting in the chair, and the black is representing, the thick black bar is representing the cushion they're sitting on. We can see the downward pressure pushing me in from gravity and the upward pressure coming back up from the seat support, and everything between the bony prominence of the ischial tuberosity and the cushion is being compressed. And we can see the 3 layers of the skin. This thin purple is the epidermis, the pink is the dermis, the yellow is our hypodermis, and the red is representing our muscles, our blood vessel, and all the soft tissue, okay? So initially, if we put someone in a wheelchair and we have, things that cause peak pressures from the previous slide, initially that epidermis is only going to be affected. And you're going to see, because of those Langerhans cells, you're going to see a reddening of the skin or maybe a temperature change, and you are dealing now with a stage 1 pressure injury. But if you allow that pressure to continue and you do nothing about it, eventually that pressure and that compression is going to get to be so much that it's now going to break through into the dermal layer of the skin. The epidermal will break open, and you're now going to go down into the second layer of your skin, causing an open wound, and you're now dealing with a stage 2 wound. And a good thing to, well, not a good thing to note, but a thing to note is that 50% of wounds in a nursing home setting are stage 2s. So we have 50% are already open wounds. All right, do nothing about it, and you start to dig into, you've broken through the epidermis, you've broken through the dermis, and now we're going into the third layer of your skin, which is your hypodermis, that fatty layer. So now you have a wound that is open and deep, going through all three layers of the skin, and you're dealing with the stage 3. And we know that we start to get in trouble from the state survey perspective when this happens, but when we really get into hot water is if we allow a stage 4 wound to occur. And so the stage 4 wound goes through all three layers of the skin and now is making its way into the muscle, the blood capillaries, and even in the worst case, the bone. And we really do get dinged for stage 4 wounds. So this is how the mechanism of pressure attacks us in the seated posture. So now what we're going to do is we're going to move into shear. And why is shear, why do I call it the silent extrinsic factor? I'm going to back up one more slide again. And the reason is, when I'm showing you the mechanism of pressure, we see it starting at the epidermis, and then it works its way through the layers of the skin down to the bone. But shear actually is a deep tissue injury, a DTI. It doesn't start superficially, it starts deep. The injury actually starts where the bone and the muscle meet, and then it works its way through the layers of the skin, the third layer, then the second layer, then the first layer. So it works its way upward and outward. And so usually the first sign that someone even has a wound occurring from shear is pain. And so your patient says, I have so much pain in my sacrum. You go and observe them, and we're used to seeing reddening or an open area, but we don't see that with shear. It's closed. There's no reddening. So we're like, well, there's nothing going on, but that person feels something going on. They feel it happening between the bone and the muscle. And then by the time it does make its way out to the epidermis, it's already very advanced and too late, and you've gone through all layers of the skin. So a lot of times I say it works silently because it doesn't really show us the typical visual signs that a wound from pressure will show us. All right, and so shear is a very difficult concept for healthcare providers to grasp for many reasons. And I'm putting all the barriers up on the screen for you that for time's sake, I'm not going to read out to you. But shear is something that has been not given so much attention. For example, when I was in school 21 years ago, they didn't really even talk about this. They talked a lot about pressure, but they didn't really talk about shear. And over the last decade is probably where it's really gained more of its popularity, and we realize that a shear wound is actually much more dangerous than a wound from pressure alone. And part of that is because we just didn't understand it. And so what I'm going to do for you today is we're going to look at the barrier, which is written in black, and then I'm going to teach you what's written in blue. So I'm going to teach you the types of friction. I'm going to teach you what does it mean, the coefficient of friction, and why is that important in my cushion cover. What is the true definition of shear? When does it happen? Does it happen when my patient is static or in movement? And why is it more dangerous? And then how do I tackle it through my equipment choices? So we are not engineers, and we do not have to know the ins and outs of friction, but we do need to know what is the type of friction that attacks us in seated posture. So I am going to just quickly name you the types of friction and then focus on the one that actually attacks us. But one thing that I want you to understand is that friction is not two surfaces rubbing against each other. Friction actually is what causes something that's in movement to stop, or it's what doesn't allow something that stopped to start moving. So friction are like what I call the brakes. They stop something from movement, or they don't allow something to start moving. So the first type of friction is fluid friction, and this occurs when a solid is moving through a fluid, okay? That's obviously not what's going on in the seated posture. The second type of friction is rolling friction, and this occurs when an object is rolling across another surface, and the surface that it's rolling on has some type of coefficient of friction and will slow it down to come to a stop. Dynamic kinetic friction exists in something that's already in movement. So something's moving just like this basketball player, and then friction slows the person down and eventually causes them to stop. And then we have static friction. And this is what we are concerned with because this is what's attacking us in the seated posture. And static friction is what I call the gripping friction. It actually grabs something to stop it from moving, okay? And in the seated posture, the thing that's being grasped and gripped is our skin and our soft tissue. So the 3 layers of the skin, the muscle, the blood capillaries, all of that is being gripped by the cushion cover to stop that person from sliding out of their wheelchair. But as that is being grasped, and maybe the skeleton underneath wants to keep moving, usually there's going to be physical wear and tear of the objects that are being, grasped. And as I said, that's the skin and soft tissue and the blood capillaries, and so there's usually some tearing and some damage to those, and that's where we see shear starting to occur. Okay, so moving to the next slide, there is a term called the coefficient of friction, and this is extremely important for you to understand. And friction is not a bad thing. It actually can be a good thing because it's what keeps us on the ground and we're not floating through air, right? It's what keeps us from sliding off a bed. It's what keeps us from sliding out of a chair. And so our cushion covers and our mattress covers purposely have to have a higher coefficient of friction so we don't slide right on out of a wheelchair like a slip and slide. So to make you understand it a little bit better, something that has a low coefficient of friction has low resistance and will be freely able to move across another surface, okay? So think of Bambi on ice. There is not much friction there. As ice has a very low coefficient of friction, and Bambi couldn't even get his footing because he can slide all over and move all over, okay? And if you think of a seat cushion, if we were to make a seat cushion of ice, as soon as you put that person on that cushion, they're going to slide right on out of their wheelchair. So that's why we don't make cushion covers with something that has a very, very low coefficient of friction. Something with a high coefficient of friction actually has high resistance to something sliding across it. So it's not going to let something move, and if it does move, it's not going to move very far, and then, so it's going to take someone a while to slide off of that if gravity really takes effect, okay? And so a good example of that would be concrete. If we made a cushion out of concrete or denim, you put that person on it, they're not going to slide out like with the ice, okay? And so we kind of have to find that happy medium and as a manufacturer to make a cover that you don't slide out, but you're not being stuck in it, okay? So just think that with something that has a high static friction, if there's a lot of static friction, then that is a material that has a high coefficient of friction, okay? And this is a perfect example to show this. So here you have someone sitting in his chair, and he's functionally reaching for a cup of coffee. And you can see in this video that his pelvis is going from an anterior to a posterior pelvic tilt. So his skeleton is moving, but he's not sliding out of his chair. And the reason why is because this cushion cover is made purposely with a high coefficient of friction that's going to grasp his skin and his soft tissue so that he doesn't come sliding out of that chair, okay? All right, so when does shear occur? It doesn't occur when I'm just sitting here. It occurs when I start moving. And why? Why does it occur when I start moving? Because remember, this cushion cover is grasping your skin and your tissue. So it's going to grab everything here to not make me slide out of my chair. But this bony prominence, my IT, as I'm moving either voluntarily or involuntarily, is going to be moving. So in this picture of this video of this gentleman, he's going from an anterior pelvic tilt to a posterior pelvic tilt, but his body's not moving. So the skin and tissue is grasped, but the bone is still moving, so we get this motion. And I want you to do this in your hand. I want you to hold your hand out, push your fingers down, and try to slide forward, but don't let your hands slide forward. And you can see your skin being, kind of like you see the oppositional force, and you can see and feel how hard that might be on this area right here because it's not able to move, okay? So what happens then? So why does this get to be so detrimental, especially for our elderly population? Because their skin isn't young and healthy. It can't withstand this over and over and over again. We lost all of those properties that let you let your skin be stretched and then pop back without any injury. We have all of those changes that I talked about, that when we push it and we strain it, boom, it's eventually going to break open, okay? So we have shear, which now we understand the definition. It's not friction alone. It's the downward pressure being pushed down from the bone, from gravity, and the static friction. So you're being pushed and the bone might be moving, but the skin and the tissue is not. So you can see that right here. The bone is moving, but the static coefficient of friction is high enough on the cushion cover that the person's skin and tissue is grabbed so the person doesn't fall out of the chair. So you have that constant frictional force happening right there. And when, again, we're elderly and we're having this happen to us, no big deal. But we're elderly, our collagen, our fiber, our elastin is not there. We don't have as much hydration. The more we push, boom, the more it's going to break open and really injure that skin and soft tissue. And I really love using this analogy with the car. So the car really is representative of the body. The car is not going anywhere. We're not falling out of our chair. But our bony prominence, our skeleton, our pelvis is going into anterior and posterior pelvic tilt, or maybe from, an obliquity, going from side to side. So the pelvis is constantly moving, but our body is not, because the brakes are on. We have that frictional force stopping our body from going. But the skin and the tissue, which is representative of the paper, is constantly having this oppositional force of stopping and moving. And so that is what is being torn and shredded and destroyed and deformed. And that is constantly happening, and there's no point of return, and you will get a pressure injury. So the skin and the tissue are being shredded while the pelvis is moving, but the body is being stopped. All right, so I'm very quickly going to side by side just compare the mechanisms of pressure and shear to make you understand why they're different and why one might be more detrimental to the other. So again, pressure is very simple for us to understand. We feel it. It happens when I'm just sitting. I'm not moving. I'm just sitting here for a prolonged period of time. But I'm sitting on something, some bony prominence, like my sacrum or my ischial tuberosity or both, and I'm putting constant pressure coming down from gravity and upward from the seat support, okay? And so what's happening is all of the skin and soft tissue between is being compressed. And that constant compression, if it's left long enough, is going to cut off the oxygen supply, it's going to cut off the nutrients, and we're going to go into a state of ischemia. And if we leave that state for a long period of time, we're suffocating our skin and our soft tissue. That will lead to tissue death and pressure injury development. But if I were to take that pressure off, boing, my skin would probably bounce back. Unless I left it for so long, like our geriatric population, they can't get back out of it, they can't release the load themselves, and they sit in these wheelchairs for 8 to 10 hours at a time, constantly under compression, and the skin will break open. However, with the mechanism of shear, I'm not just sitting straight, I'm moving, or maybe I'm agitated in my chair and I'm constantly moving, or I'm sliding down because I don't have the strength to sit up. And so our pelvis is in movement, or our skeleton is in movement, but our skin and our tissue, again, are stuck to the chair's surface because of that high coefficient of friction. It's being grasped. And while the bone is moving, that skin is not moving. So we have this oppositional stress and strain constantly going on. And we're going to see that permanent cell deformation from that constant stress and strain that will break open the skin because our skin doesn't have the capability to pop back. Those blood capillaries that are inside of our skin cells, in our dermis, in our hypodermis, in the muscle below, they're going to start to be torn because, again, you're doing this motion constantly. It's almost like erasing on a piece of paper until you make a hole. That's exactly what it's doing, and it's going to break it open. And then when you tear a blood capillary, there is no oxygen delivery. There is no exchange because the capillary is done for, and the ischemia that would happen from compression alone is even more amplified. And the tissue death is going to occur and pressure injury will occur. And the thing is about the mechanism of shear, the pressure, it will take hours. Shear can happen in a matter of minutes. And that is one thing that the NPIEP is trying to get everyone to understand, is that it is much more detrimental because it happens in a much shorter period of time. And it happens deep and works its way out. All right, so it is so dangerous for all the reasons that I just said. We're more familiar with that wound that starts here, and it's red, but I know it's just affecting out here. And as soon as I see that redness or that temperature change, I'm going to do something. But shear, again, it doesn't start up here. It starts down here where the bone is rubbing against the muscle, and it works its way outward, going through all layers of the skin. And by the time it does rear its ugly head and change the color of the epidermis, it's too late, and it's already at a very advanced stage. And so why is this much more dangerous for the elderly? Remember 3 of those key changes that I talked about. The skin becomes thinner. The blood vessels become more fragile. And so with that constant, stress and strain, they're going to break open more easily. We've lost the number of collagen elastin. They're no longer interconnected, interwoven, really nice and tight to give us tensile strength, to give us the pliability. They're now disorganized and barely hanging on for dear life, and so it's much easier to break open elderly skin. And also, we don't have the hydration level, so we don't have that viscoelastic property to really give like it would if we were in water and bounce back. And so we see more permanent cell deformation and death much quicker in an elderly patient. All right. And then the other image that I think I love is that, in that deep layer that actually connects the fatty hypodermis to the muscles, to the bone, we have a lot of fibrous bands, but that's lost as well. So we don't have the same firmness and resilience in elderly skin as we do in young skin. And I think that these 3 images really do a great job. This is an actual cross-section of a true cell, okay? And so here's a cell with no load. It's perfectly healthy. It's kind of just hanging out. And then a load is put on it. So you're compressing it. And you can see that it gets compressed. But if I were to take that load off, boing, it would bounce back to this no load state. But if I compress it, plus I start to give the friction component, so I downward and friction, you're going to start to distort and tear and deform the structures within the cell, okay? And once I remove that load, it doesn't matter. Once something's torn and destroyed, it can never come back to this state. So that is why shear does so much more damage than just pressure alone. And because pressure and shear cut off oxygen supply when shear is present and when damage has happened, it takes that much longer to heal the injury because the oxygen supply has been really cut off. All right, and then the last one is understanding microclimate. And again, I think this is the extrinsic factor that we seem to understand better because we feel it all the time, right? And I say that because microclimate, by definition, is the climate of a very small area in comparison to the area around it. So when it comes to the seated posture, that's where your legs and your glutes are making contact with the seat, or where your back is making contact with the seat support, right, on the back support. And think about sitting outside watching a baseball game under the sun, and you can feel that microclimate. You feel where you're touching the seat. Man, I'm getting hot under my butt, right? So you stand up, and when you stand up, you're all sweaty, and that's a microclimate. You had increased temperature under there, and you had increased moisture. And that happens usually, like I said, for an increase of temperature at the skin surface. And whenever the skin is touching something, you're going to have an increased temperature. And also because of increased humidity. And that happens with our elderly mostly because of urinary incontinence or fecal incontinence, or maybe they have drainage from the existing wound, or maybe you've made it too hot for them and they're just sweating to death, okay? So, and also it can happen when you wear clothing that is non-breathable. So like my sweater is cotton and it's breathable, but my shirt underneath is not. This shirt is not breathable. And if I were to be sitting in the hot sun with this, you better believe I'm going to be forming a microclimate because I'm going to sweat to death in it. All right. And you have to think back about some of those age-related changes. And when it comes to microclimate, our elderly population is more susceptible because, again, we've lost sweat glands. So we have a diminished number of sweat glands that says, as the body temperature rises, I don't have that same capability to make myself sweat, to excrete it to my epidermis, or it to evaporate to me to then be able to cool my body temperature down. So we just don't dissipate heat as well as we get older. And then again, we've lost sebaceous glands as well, which means that we have less oil production. Our skin becomes drier and more brittle. It's much easier to break open something dry and brittle versus something moist and lubricated. And then, of course, with the excess moisture, it's going to macerate this top layer because it's just going to absorb it like a sponge. And you're going to see, just like in this runner's foot, the skin is just going to start to slough off, and the deeper layers are going to be more susceptible. Okay, and microclimate, speaking about microclimate, I'm getting hot. Microclimate really does its own damage, but it's even worse because it also increases the effects of pressure and shear. So the last time I looked was about 5 years ago, and the statistics said that microclimate can actually increase the effects of pressure and shear by at least 5%. And why? So when we have elevated body temperature, so we have a microclimate, there's a higher temperature between the seat support and your body. What that does, it increases metabolic rate. It's almost like when we go exercise, right? We increase our metabolic rate, we increase our body's temperature, but we need more oxygen delivery to the tissues in order for that to be able to be sustained. But what's the problem? When we have pressure and shear, what are we doing? We're cutting off oxygen supply. So now we have a situation where we need more oxygen, so we have a lot of demand, but we don't have a lot of supply because pressure and shear cut it off, either through ischemia or through destroying the blood vessels. And so when you have that situation of more demand, less supply, then ischemia will actually happen even more quickly when the body's temperature is raised. As well, think about what I talked about, the coefficient of friction. So if you were to have a cushion made of concrete, and then you added the microclimate and you put moisture on top of that concrete, moisture actually increases the coefficient of friction. So it makes it even harder for something to start movement or to slide across something. So more moisture you have, the higher the coefficient of friction, the more shear stress and strain you're going to see happening. And then again, think back about that the more moisture, the more it soaks in, the increased risk of maceration, and the lower layers of the skin are going to be more susceptible. All right, so now what you should be asking yourself is, okay, Anna, I get the mechanisms. Fantastic. I see why it's attacking us in the seated posture, but what should I do? What should I be looking for in my equipment choices? And what we're going to do is, again, go through each one by one and see what I should be looking for. What can a cushion or a back support have built in that will help me fight against each one? And fighting pressure, there's something that a rule of thumb that just we have to remember, that we should be aiming for whenever we place someone on a cushion and whenever we place someone against a back support. And that should be that we want their body to make the most contact with the back support and the cushion as possible. So I want as much of the gluteal surface, I want as much of the femur to touch the cushion, and I want as much as the top of the glutes and the top of the bottom and the entire spine to hit as much of the back support as possible, okay? Because the rule of thumb is the greater the surface area, the smaller the peak pressure. The smaller the surface area, the greater the pressure is digging right into that small, tiny little area, okay? So think of this finger. This little finger is going to be my sacrum, and this is the only thing making contact, and it's pushing into my cushion. Well, eventually, it's going to break right through, okay? But if it's not just my sacrum, but it's my entire gluteal surface, all of my femurs now making contact, you're not going to be able to break right through in a small spot because you have so much more contact area being made. So again, the rule of thumb, the greater the surface area, the more contact you're making with the support surface, the smaller the peak pressure, the smaller the risk of breaking open and developing a wound. And how do we accomplish that? We accomplish that through two methods, pressure redistribution methods, immersion and envelopment, or offloading. And so immersion is the principle of something being sunk in. So instead of it just sitting on top, it actually sinks that object in and then can make more contact with more of that object. If you take it one step further and you actually then envelop it, that's like mimicking that object's shape and filling in every nook and cranny. So instead of just making contact with the outside, it's going to fill in every nook and cranny and make the greatest surface area possible. And I always kind of compare this to a mitten versus a glove, okay? So if I have a mitten and I put my hand in, the mitten is just going to make contact with the outside surface of my fingers. But if I then, that would be immersion, okay? If I then put my hand into a glove, I'm not just making contact with the outside, I'm making contact with every single surface of every single part of my finger and my hand, because the glove hits every nook and cranny. And that's what envelopment is, immersion and envelopment. And envelopment will obviously give you a greater surface area because it's making contact and making your exact shape. The second method of pressure redistribution is called offloading. And that can be either complete, where it completely doesn't touch a certain area of your body, or it's partial, where it actually makes contact with, partially makes contact with that high risk vulnerable area. But in both cases, you're taking pressure from that vulnerable area and you're redistributing the pressure to something that can withstand a more tolerant tissue that can really stand up against that constant pressure. So usually that's over here on the outside, and you can see that on these pictures, outside of the fattier part of our glutes, where we have more cushion, and also down our femurs, okay? All right, but in order to be able to offload, there are certain contours, certain hills and valleys and shapes that kind of need to be built into a cushion to achieve that. And they are the lateral tapered adductors, the medial abductor, and then a deep posterior pelvic well. And with the lateral tapered adductors, what they are, and it's called lateral because they're obviously on the lateral aspect of the cushion, and they're tapered because they're thinner in the front and they become thicker towards the back. And they're also higher towards the back. And they do that for two reasons. Number one, they become higher so that it can actually create a deep pelvic well so that you can partially suspend the highest risk areas, which is your sacrum, coccyx, and ITs. Okay, so they're higher for that reason, and also they're higher because then your greater trochanters sit on them, and they actually force the head of the femur into its acetabulum. So it actually stabilizes your pelvis so that you can prevent some of that unwanted movement, because remember, shear happens when someone goes into movement, and a lot of the movement within our geriatric population is involuntary because of lack of trunk strength and gravity pushing them down. So we look for a cushion that can keep them stable and keep them in the position when their body can't do it for them. And then the adductor also, because of its name, keeps the legs adducted. And that in combination with this middle piece, which is the abductor, which is going to keep your legs in the abduction, actually form these really nice leg troughs that sit deep in the cushion. So again, you're sitting in the cushion, not on the cushion. And your legs fall into it and immerse into it. And then not only does the bottom surface of your femur make contact, but since you sink in, the whole lateral surfaces of your femurs make contact as well. So again, instead of a smaller surface area, you're getting a greater contact area to, again, redistribute pressure over the greatest area possible to prevent a wound. All right, so now fighting shear. And so if you recall, shear has both a pressure and a friction component. I just talked to you about how to fight pressure, so I'm not going to go over that piece of it again. You do the same thing for shear when you're thinking of the pressure component. But when it comes to the frictional component of shear, there are some things that you can do. We talked about coefficient of friction and how something with a high coefficient of friction actually makes you grasp to the chair, the seat surface better or more firmly, correct? So there are high-risk areas, and we showed you that in one of the first slides, the ITs, the sacrum, coccyx. So we can strategically place a fabric that has a low coefficient of friction that won't cause you not to move, but instead will actually allow the bone and the tissue to move together. All right, and we're going to talk about that more in a second. The second thing is you can use certain mediums in your cushion choices that actually give with you and move with you instead of against you. And then thirdly, through the geometry that we just talked about, you can stabilize someone better to prevent them from moving, because remember that friction comes when the person starts to be in movement. So if we use all the geometry that I just showed you through the offloading cushion, for example, you'll stabilize them and you'll reduce that frictional component. So talking specifically about that shear reducing fabric, and again, I must talk about the NPIP in their recommendations, and they do recommend in their clinical practice guidelines using shear reducing fabric. And there are lots of studies out there that prove how this actually can reduce shear, especially when used on foam products. Okay, so what they do with this fabric is they take a high-risk area, so right under the pelvis at the IT, sacrum, and coccyx, and they make this specific patch of fabric with a very low coefficient of friction. So again, you don't have this kind of oppositional force going on. The bone and the skin and the tissue will move together just in that area. So when that person reaches for coffee, or reaches to brush his teeth, or reaches up to get something, the bone and the skin move together instead of against each other. But the rest of the cushion cover still has a higher coefficient of friction, so you don't go sliding off of it like a slip and slide. And then the second thing to do that you can do is there are lots of air options out there that through its actual medium, what the cushion is made of has a lower coefficient of friction, so that it will actually give with you as you move, and the skin again and the bone will move together instead of against you. Okay? And then lastly, remember everything I talked about with the pressure component. Look for something that increases contact area, redistributes pressure away, and that can be either through immersion and envelopment or through offloading. And as well, when you're dealing with someone that has a lot of instability or weakness, look for cushions that might have those contours that increase the stability, really lock the head of the femur into acetabulum, really lock that pelvis into stable. All right, and then I have to say, another way to protect people from shear is don't force them into a position that their body can't tolerate. Eventually, they will slide into a position that their body can tolerate. So remember, we have a lot of chairs that have us fixed 90 degrees in our facilities. Well, our clientele probably can't even get to 90 degrees. And if they can only tolerate it for a couple seconds. Think about you sitting in this course. You've moved a million times to alleviate pressure. Well, they can't do that. Once they slide, they can't bring themselves back up. So once they slide down, you're going to see those peak pressures happening. You're going to see that frictional force continue to happen as they go into movement. And so you want to stabilize that person, and you want to make sure that you're putting them into a position that their range of motion can tolerate. So if they can tolerate 110, then open the seat to back angle to 110, because if you force them at 90, they will get out of it. And then you can do that through two ways. Some wheelchairs through its actual frame, and you can see that right here. This is kind of like a little screw system that you actually unscrew it, open it to where you want it, then you screw it there, and the chair is set to that 110 degrees, let's say. Or you can use a specialized back support that through its hardware, you can open or close seat to back angle, usually up to 18 to 20 degrees. All right, you want to protect from shear, especially in the trunk. Again, you have to recall that the back support is just as critical as the cushion. You want the same thing in a back support that you wanted in the cushion. You want to immerse it in the spine. You want to envelop it. You want to capture its curvature, fit it like a glove so that you don't have peak pressures. So if you can open seat to back angle through your back support, you're going to be able to get the pelvis all the way back, make more contact with the femur because the person's sitting back in the chair now. You're going to have more contact with the spine. And then if you take it one step further and you use a back support that actually can be adjusted and can fit that person's curvature like a glove, then you don't have just one point of contact digging in and breaking that area open, or maybe two. You actually have even pressure entering through the entire spine. And when you can actually fit that person's spine like a glove, you're also stabilizing the entire pelvis to prevent that unwanted movement. And again, remember, shear occurs when someone goes into movement. And then fighting microclimate, that's the last piece. And with microclimate, what I do often is I talk to the nursing staff, and I really, or the family, or the patients themselves, and I really go over and look at their ADL routine. And you want to stay away from anything that's going to increase a microclimate. Don't bathe them in super hot water. Don't use harsh soaps that are going to take away that barrier and make that oil barrier go away even faster. Apply a barrier cream to kind of replenish what they've lost naturally. Make sure they're not sitting in wet, drain, dressings, or make sure you've got a good changing schedule. Make sure their clothing is breathable, and make sure the environment is very mild and doesn't cause them to sweat too much and increase that risk of a microclimate. And when it comes to buying products, you might want to look into products that have mesh liners or perforated covers so that air can be permeable and moisture can get through as well. When it comes to foam products, you might even want to think about using a incontinence liner so that the water doesn't sink into the foam. And definitely look for some of these descriptors that will give you the clues that this product is meant to fight against microclimate. And the last slide for today is, my goal today was to give you the knowledge, and knowledge truly is power. If you understand the mechanism of all three extrinsic factors, you understand how they're attacking the body, and you understand what's happening to the elderly population and why they're more susceptible, then it makes sense why we should be listening to the NPIP guidelines and looking for skin protection properties in our equipment choices to help us to prevent the risk of wounds in our elderly population.
So now, for anyone interested in learning about how Direct Supply can help you navigate these new technologies and products, please help me welcome our dedicated product consultant, Kelly Sullivan.
Hi, I'm Kelly Sullivan, Senior Product Consultant here at Direct Supply. Today we're going to be looking at a few cushions. I brought 3 with me. They're all going to answer to how to create a microclimate on the surface that's nice and cool, how to mitigate pressure from underneath the individual with the properties of the cushions, and also how to mitigate shear, which we know can lead to pressure injuries. Before I get into the details of the 3 cushions that I brought with me today, I'd like to spend just a minute or two with a video to show exactly some of the technology that's built in or incorporated with the V-Care cushions, which are the 2 of the cushions I'm going to show you today. So we'll start there, and then we'll come back and I'll go through the details of the 3 models that I have with me today.
The unique V-Care air technology, which uses the small air-filled smart cells, was developed in cooperation with the Amsterdam Rehabilitation Center. It was awarded the Grand Prix at the Salon des Inventions in Geneva, Switzerland. V-Care develops and produces its product line in the Netherlands for customers all over the world. When you sit on a V-Care wheelchair cushion, you are supported by hundreds of smart cells. The layers of cells inside the cushion compartments move with so little friction that the effect resembles the behavior of a viscous fluid, slowly adjusting to the shape of your body. Also, because smart cells deform individually, they conform to your body's contours. The result is superior pressure redistribution. Moreover, the design of the cushion compartments make the V-Care cushion ultra-stable and prevent the person sitting on it from sliding forward. This reduces shear forces to a bare minimum, helping to maintain optimal posture, functional positioning, and high-performance skin protection. V-Care Smart Cell cushions are extremely user-friendly. The well-balanced filling rate ensures that V-Care cushions are ready to use. V-Care. Relief by air.
All right, now that we've had a chance to look at the technology behind the V-Care cushions, I have 2 here to show you today. And I want to take you through exactly how they're built and engineered to help you and your resident at your building. So when we look at the first one I brought with me today, this one's called the Vector O2 cushion. And if I open it up, you can see that nice cover there. It's nice and breathable. I'm going to pull back this cushion cover and show you all the various different compartments here. So as you saw in the video, depending on the model, there are different amount of cushion compartments, if you will. This one has 9 compartments. So really it is one of the most sturdiest cushions they've got in this product line, meaning it's going to really keep that resident stabilized on the cushion surface. It allows for a lot of adjustability too. So if you're trying to create a pummel, for instance, or if you would like to create more of a shelf up in the front for anti-thrust, if you would like to, maybe someone laterally leans to one side and really build up one side of the cushion, you can do that. So there's lots of options to change the contours of the cushion surface. Also, if we get in a little closer, you'll see these little pinholes. That's going to help with that moisture buildup, really keeping that surface nice and cool and keeping that air circulating on that surface, that microclimate that I mentioned earlier on in this discussion. One of my favorite things I love about the VCare technology is that this whole cushion goes right into the washing machine. As we look at this crazy world we live in right now, infection control is top of mind. And so being able to easily clean the cushion in a washing machine, the whole cushion itself is really a nice feature. So this is the Vector. Again, one of the cushions that you might want to consider if you're looking for a good stable surface that allows for a lot of adjustability. I'm going to move that one off to the side now. The next one we're looking at from the VCare technology is the adjuster. And there's a lot of similarities. So they both have a similar cover, nice and cool, stretch cover. I'm going to pull that off here with a non-skid bottom. And then you can see that it too has all of those little air holes to keep that surface cool. What it also has is bigger compartments. So there's fewer compartments, but there's bigger compartments, especially in that pelvic region. The reason for this is to really allow for really good immersion into the cushion, to offload that pressure from the IT bones. So if you have someone that you really want to capture a nice surface surrounding or underneath them and really allow for them to sink into that cushion to really offload that pressure, this is a great cushion to consider. It too has some adjustability. So we have several compartments here. We have 5 in total. So we can still build up the cushion in a way that can help with those positioning needs. Not as many options, but again, really helps to offload that pressure with those bigger compartments located towards the back of the cushion. So great cushion. Again, throw it right into the washing machine, same exact features as we look at, how to clean and maintain the cushion. One thing I want to show with the VCare cushion is that each compartment is separated. I'm trying not to spill all over the place here. And they come with these little air packets that you might have seen on the video. The other cushion, the Vector has this as well. And these little air packets kind of shift and move and slide as the resident moves in their seat. And this is great to mitigate shear. So we think about just those little micro movements. Maybe you're reaching for something. Your pelvic region is going to move with that movement as well, which can lead to some shear effects. And some, because of friction on a lot of cushions, a lot of the surfaces have a high coefficient of friction because you don't want them sliding out of the seat, but you also need to have some movement under that resin as well so that they are not sticking to the seat and it's not injuring them and their skin integrity. So wanted to mention that as well. The third cushion I brought with me today is not an air cushion, but we do categorize it as an advanced pressure management solution. This is called the Comfort Shield. And it is a through and through foam. So right out of the box, I can put this right on my seat and I can get the resident on the cushion and be part of that treatment process. Of course, with all those other things that need to happen as well, like hydration and repositioning and whatnot. But a great advanced pressure solution as we're looking at someone with pressure injuries. This one is going to have an interesting cover. Now you can order this glideware, which I'm going to speak to here in a second, with the VCare cushions as well. But we can see here the glideware, what I'm speaking to, is this piece right here in that pelvic region of the top cover of this cushion. And what is different about that between this high coefficient of friction, which we need to mitigate that slide, is that this piece here has 2 layers of material that slide together and move with the resident. So again, when we talk about shear and helping to limit the amount of shear that they're going to experience on that surface, the glideware piece right in that IT and coccyx region, there's a reason for that. So we want to make sure that the glideware is in that position so that we can help with those micro movements and that shear issue that we might be facing. Great, great invention. So I recommend that even with the other two, if you're looking at the VCare cushions, that you consider them with glideware covers. I'm going to open it up. And inside the shield cushion we have here, another cover. And this is a great second cover that is an incontinence liner. This is going to help protect the integrity of the foam inside of the cushion. So if you do have someone that has frequent episodes of incontinence, this might be a good solution for you because you have that additional protection for the cushion. As I open up the cushion, to kind of give you some details of how this is constructed and why a foam cushion is considered an advanced pressure solution, because we're used to just seeing air typically. Let's open this all the way up. Here you can see that it has some contouring. So we have a nice saddle shape to it. So it's really going to help align the legs. It also has, way in the back here, kind of a carved out pelvic region. So that's where it's going to really offload that pressure from the IT zone. And then you can see here too, there's a coccyx cutout. So that's going to offload pressure from that tailbone. The design itself with the built up sides also helps to kind of help remind or push that person back into an upright position. So when we talk about posture and getting that person upright, this is a really great design. It's engineered for that reason. 3 layers of foam. So the bottom layer is going to be kind of firm, so it prevents bottoming out. But that top layer, we want comfort, but more importantly, we want pressure management properties built into the cushion. That top layer is going to be memory foam, so we have nice immersion into the cushion itself. The shield pressure maps like a Roho cushion, so it truly is an advanced pressure solution for you. When you're looking at the 3 options I have shown you today, consider, the resident and who you're working with. Do they need to have that cup underneath them, that high contact of that surface underneath them, depending on the maybe level or stage of injury that you're dealing with? Do you need something more stabilized for someone? Maybe they're amputee, maybe they have other conditions where you really need a solid surface underneath them, and you can do that with various different compartments with that vector option. Maybe you're looking for very low maintenance, out of the box solution, but still is an advanced pressure management option that's comfortable and maps well, then this shield might be one to consider. So hopefully today you saw a few products that might work for a resident or two that you're working with at one of the communities you serve in. And if you have any additional questions, you can call your account manager and they can connect you with me if you have additional specific questions as it pertains to these questions we discussed today. So thank you for your time.
Thank you so much, Kelly. So we'd like to send our thanks to everybody who took the time to join us today. And a special big thank you to Anna and Kelly both for sharing their time and expertise with us. If you have any questions about the items that were discussed during that product portion, you can also feel free to email us webinars@directsupply.com. That wraps everything up today. Thank you so much and enjoy the rest of your day.